Good afternoon, everybody. We'll be talking very briefly about excessive sympathetic tone here, just a really brief overview before we switch over to Dr. Condi. So, sympathetic nervous system hyperreactivity symptoms can come in many different forms, but often we'll hear patients talk about an increased startle response. Someone may walk in the room and they jump out of their skin and take, 10, 15 minutes to calm down, if at all. Frequent nightmares, panic attacks, but specifically, they'll often say, I wasn't particularly stressed or focused on anything cognitively, and yet my body sort of went into a panic attack, almost like a panic attack from the neck down. Emotional lability, muscle fasciculations, that can particularly happen after an orthostatic stressor or some other physiological challenge. Other sleep disturbances, insomnia, feeling more wired or alert or revved up. The more tired they get, the wired but tired sensation. Again, nightmares, frequent nighttime awakenings, total disruption of the circadian rhythm with switching of the day and night. Medication sensitivities, and those can be sensitivities that are independent of the pharmacological action of the drugs. If you've heard me talk before, you've heard me mention that sometimes patients will tell me, I took a Tylenol and I didn't sleep for 3 days. And clearly that's not the pharmacological action of the acetaminophen there, but it's the body's sympathetic reaction to that presence of that foreign substance to begin with, and other sensory sensitivities may be signs as well. So when we are managing patients with complex chronic illness, we do need to think about the impact of sympathetic overdrive. And we have sort of a host of different treatments that we can consider depending on the patient. One of the first things a lot of us will reach for are traditional beta blockers, not because we're trying to necessarily control the heart rate or the blood pressure per se, but because blocking beta receptors of the sympathetic nervous system is an effective tool here. And so while we may monitor heart rate as a sign that we're doing better for sympathetic management, that's not actually the goal itself. It's just sort of a marker, a surrogate marker for doing better. So propranolol is a pretty useful drug, both the short-acting versions and there's an extended release, a 24-hour formulation that we'll use. I really like the extended release formulation. I have people take it before bed. It sort of helps with that wired but tired sensation, but still carries over to some degree into the next day. When the doses of extended release are too high, atenolol as a BID formulation is sometimes helpful. And if you have the blood pressure room, metoprolol can be helpful as well. Now, many of you may be familiar with Corlinor or ivabradine, a heart rate suppressor as well that is not a direct beta blocker. And so I don't tend to reach for this quite as much because it doesn't have any direct effects on the sympathetic nervous system. That being said, it still can be used a little bit as a tool to reduce kind of the feedback loop that you might experience from sympathetic overdrive. So if somebody is having a physiological stressor, they may not increase their heart rate quite as much with something like ivabradine or Corlinor on board, and then not get secondary and tertiary signals that their body is in distress. So it can still interrupt that cycle to a degree, but I don't find it quite as beneficial as beta blockers. Alpha blockers. Remember, there's alpha and beta receptors in that sympathetic nervous system. So alpha blockers can be another great tool. I particularly like to reach for clonidine, which can be used just before bed. It can be used throughout the day in a BID formulation. There's clonidine patches, a lot of great ways to get this on board. And I would remind people, I know I was taught that clonidine is this really potent blood pressure dropper. And in fact, in clinical practice in the outpatient setting, I haven't found that to be true. I remember back in residency in the ER, people would come in distress with really high blood pressures, and clonidine would bring everything down, right? Or maybe labetalol too, but clonidine was something they always reached for. And those patients were generally in some kind of sympathetic distress. They were in urosepsis or having an MI or some other terrible thing was happening. When you take people who are otherwise normotensive, though, but are still having this sympathetic overdrive, I find that the blood pressure doesn't drop quite as much as you might think it would, but the sympathetic blockade is very effective nonetheless. Occasionally, I will reach for guanfacine, which is a selective alpha 2A agonist. This is sort of a weak agonist there. And I would say that I'll reach for this when I'm also looking for sort of a weak stimulant property. So this is actually used in the ADD or ADHD world to help with concentration and focus. There have been some studies in long COVID where it's been combined with other medications, but it is a tool that we have. And then I have patients who've done better with prazosin, at least at nighttime when they continue to have intrusive nightmares or excessive sympathetic overdrive. They'll often sort of have a PTSD-like presentation at night and maybe a legitimate PTSD trigger that's sort of interacting with or overlapping with the dysautonomia syndrome from their post-viral illness as well. So prazosin can be an interesting tool there. It is worth bringing up the role of benzodiazepines. So these, of course, bind to GABA A receptors and they potentiate GABA neurotransmission, increasing chloride influx into neurons and increasing the neuronal excitability threshold. I tend to reach for things like diazepam, clonazepam, or lorazepam when I need it. Diazepam in particular is also maybe my favorite muscle relaxant when we need that for excessive sympathetic muscle tone that we'll see in people, particularly in those that are posturing in their neck and shoulder girdle if they may have anatomical issues there from their hypermobility. Clonazepam is sometimes helpful when you just need the volume to be turned down throughout the course of the day or for an extended period of time. Or occasionally, some people don't have as much sympathetic overdrive, but when it does kick in, it's debilitating, and a little bit of as needed lorazepam can be really helpful there. Any peripheral nervous system as well. Cell benzodiazepine receptors, of course, glial cells have been implicated in part of the neuroinflammation of post-viral illnesses, and we think the peripheral nervous system is particularly important in this set of illnesses. It's why I actually still like benzodiazepines in this illness, whereas they've fallen out of favor in most of traditional medicine at this time, because we are looking for that dirty drug effect, that peripheral nervous system effect to actually get the outcome we're looking for here. The peripheral benzodiazepine receptors are also present in particularly high concentrations on immune cells, platelets, and erythrocytes within the gastrointestinal tract, which may also be relevant for a multisystem illness like a post-viral illness. And some benzodiazepine receptors have also been implicated in regulation of mitochondrial function. Now, whether or not this has a direct effect on the mitochondrial dysfunction that we see in ME/CFS or post-viral illnesses is not clear, but it's certainly something to consider when we reach for these drugs. Stellate ganglion blocks are another wonderful tool that we can use to calm down the sympathetic nervous system. Dr. Conde will be jumping into these shortly. Vagal maneuvers are another technique that people may use. So there are cranial nerves that are responsible for the cardiac vagal stimulation and that participate in trigeminal brainstem vagal pathways. And these are located in the facial area, head and neck regions. And so one of the really powerful ways to activate these is to use or apply cold to these nerves. And then we actually call this the diving reflex. And it's involving a pattern of respiratory, cardiac, and vascular responses that are thought to help control oxygen conservation and survival when diving. So we can utilize that to our advantage to control excessive sympathetic signaling, particularly when cold is applied right here under the angle of the mandible to the neck or cheek. It seems to be the most effective, and it can sometimes calm things down in an active state, or even is effective for a lot of people when they start their day to actually just regulate their overall sympathetic tone and get a little bit of balancing vagal tone for the day to have less variability, less chance of ending up in that panic attack state or that wired but tired state. So some patients will tell me they'll take their shower in the morning, they'll finish it off with ice cold water for about a minute or two and run their head under it or their neck under it. Other people will fill a basin full of ice water and dunk their face in it 1 to 2 times a day. As unpleasant as that is for the 1 or 2 minutes they do it, they find the rest of their day may often go much smoother as a result. And then there are several other different mechanisms by which people can sort of exert conscious control over what is generally a subconscious process of managing the sympathetic nervous system. You may be familiar with biofeedback techniques. Meditation is used in these manners. There are several of what we call the brain retraining programs. They're marketed as retraining the limbic system. They may do those things, they may not. I'm not totally sure. But what I think is clear to me in patients who have done them is that the exercises, the tools that they're given to try to retrain their limbic system really give them some conscious control over some of their sympathetic functioning and seem to calm down sympathetic overdrive over time as a result. So I think those are kind of powerful visualization tools that open the window to helping one control their sympathetic overdrive a bit. And so there's things like the Eleanor Stein program, DNRS, the Gupta program. There's no major preference for one over the other. It's kind of whatever speaks to the patient, but they are non-pharmacological ways to try to approach this. And then I've had other patients actually tell me that the emotional freedom technique or tapping, which is maybe thought to activate some of the same areas that acupuncture might, can be another way to calm their autonomic nervous system. It's not universally beneficial, but it's certainly relatively harmless. And if it works for people, I think it's still a great tool to consider. And then we always want to think about the other comorbid conditions that occur in these post-viral illnesses when we're thinking about sympathetic overdrive, remembering that uncontrolled orthostatic intolerance can drive significant exacerbations of sympathetic overdrive. That's your sort of emergency response to physiological stressors. Mast cell activation exacerbations are often significantly worsened by sympathetic overdrive. Neurological sensitivities to light, sound, conversation, multiple sensory inputs at once, crowded rooms can be exacerbating factors. And certainly you can consider utilization of aripiprazole or dextromethorphan as beneficial in these cases. I think it's also worth mentioning that we think that craniocervical instability or atlantoaxial instability, when present, may lead to irritation of sympathetic autonomic signaling at the level of the brainstem and may potentiate sympathetic overdrive in those patients that you just can't seem to help get control of symptoms. So always consider that on your differential diagnosis when you get stuck with these symptoms. And then I would remind people that sympathetic overdrive is usually worse during post-exertional malaise. Like most of our symptoms are worse during PEM. And there's really not much you can do when you're in PEM to really speed that up other than not making it worse. With that said, I might throw out a controversial statement here and say I have had some patients who have said, well, I woke up, I'm in post-exertional malaise, I'm not doing anything, but it just keeps going and going for several days. I don't know how to get out of it. I'm literally laying there suffering, but I'm kind of awake. I'm not really asleep. I'm not really doing anything. They have found that if they do go back and use some benzodiazepines during post-exertional malaise, if they really just kind of force themselves to, quote, sleep it off, that they actually seem to recover a little more quickly. They don't have that continued neurological energy expenditure, as it were, and it does seem to help them pull out of PEM a little quicker. One quick word on stimulants. We do use stimulants in these post-viral illnesses, stimulant therapies like bupropion, modafinil, Adderall, methylphenidate, dexamphetamine, or Vyvanse. These are often used to help improve brain fog, to improve attention, and other cognitive complaints. Remember that stimulants, however, can significantly alter or worsen sympathetic overdrive or hypervigilance. So it's generally best practice to implement these therapies only after you've seen some general clinical improvement in the symptoms of sympathetic overdrive and generally across several of the other aspects of these illnesses first. I see these as not really critical to the underlying pathophysiology of ME/CFS or long COVID, but more symptom control therapies that you can add when you're continuing to try to help people improve their quality of life. That is my presentation. I will hand it over to Dr. Condi.
All right, good morning, everyone. I'm Dr. Condi. Very excited to be here. I've really enjoyed working with the Bateman Horne Institute Center and have seen some really cool stuff, cool changes in our patients' lives. How about that? And so title this is Invisible Pain, the novel use of the stellate ganglion block to change lives. Why is that going without me changing it? Okay, it gives me a time limit. So I work interventional spine and pain, and we do this shot for nerve pain in the neck and the shoulder and the arm. And it's a block that helps reduce the fight or flight response. The system's activity increases when you are stressed, in danger, physically active. It affects include increasing your heart rate and breathing ability, improving your eyesight, and slowing down processes like digestion. You want the sympathetic nervous system to work well. And in reverse, you want your sympathetic drive to work when you need it, and you want your parasympathetic drive to work when you need it. For instance, if you get excited and you catch a fish, you want to be able to digest it and sit down and reverse the process. What happens when it gets stuck? The fight or flight response. So Dr. Yelman, I saw you'd use this same picture. I loved it. When you experience something traumatic, the brain shuts down all the non-essential systems and moves into a lower brain system. This activates the sympathetic nervous system and signals the release of stress hormones, preparing you to fight, flight, or freeze, put you in this survival mode. Either you team together as a bunch of guppies against the shark, or you are running like crazy. So why would I use a stellate ganglion block for that? Well, one of the proposed mechanisms of action is that the stellate ganglion block, or SGB, might inhibit connections between that peripheral sympathetic nervous system, as well as regions of the cortex that are abnormally activated in diseases like PTSD, or some other things we'll get to in a second. So we know that PTSD affects parts of the brain and the amygdala, the hippocampus, the prefrontal cortex, and there are connections from that sympathetic nervous system that go into these areas of the brain. And when you are stuck in this overdrive, as Dr. Yelman put it, that the amygdala is that memory center, the hippocampus is the memory center, the amygdala is the emotion center, and your brain doesn't know time. It doesn't know that it's happened 20 years ago or 5 years ago. It thinks it's happening now. And so you get that emotional response when you're triggered, and that sympathetic overdrive continues while you're sleeping, which is why you get these nightmares, which is why prazosin, which I use a lot for that same thing, to help with that. And the prefrontal cortex, which is your ability to say, hey, brain, you're not being attacked right now. It's dulled. And so it actually limits the ability to think through why you're having this reaction. I had a patient who, severe PTSD, like the worst I'd ever seen, set him up for this procedure. He would jump back to his time in Vietnam and Afghanistan during this procedure, and I might as well have had a knife to his throat in his mind. And it was really interesting that you couldn't talk him out of it. His prefrontal cortex, and he's the sweetest man, was just dull, and he was gone. So this is a picture of a stellate ganglion block, how they used to do it. That's on one hand, they would just put their finger in, palpate the carotid, and move it out of the way as best they could, and inject, put the needle down and hit bone and back off and then inject. Now we use an ultrasound, a little more sophisticated, where we can see the jugular, the carotid. We could see that group where the vagus nerve is probably close by, and we sort of sneak right underneath it, right on top of the longus colli. If you can see that there, you're close to some vessels, but it's very safe because I can see it. It's like a video game. I tell my mom Mario Kart is still paying dividends years later. So we're good. So there was a study done, and this is the study done as JAMA, effective stellate ganglion block treatment PTSD. It was a controlled trial, and it was a sham controlled randomized trial that was 2 blocks, 2 weeks apart, that were effective in reducing clinician administered scale score over 8 weeks. And so this is what it looks like in, I guess, real time. I've done my best to, that's not my kid drawing on there or my 11-year-old, that's me. So if you're wondering who drew that, that was me. But you see what an ultrasound looks like of the carotid artery. The yellow circle is the hypothesized. It's hard to see exactly, but that's right where the sympathetic nervous system is running. And that longus colli is that muscle right next to that C6. It's called Chasnex tubercle. The stellate ganglion itself sits around T1 to C7, but because of where the lung comes up real close to there, as well as the vertebral artery, that we get the same effect, if not better, with less risk by coming up to this C6 tubercle because of some of its protection. And the medication flows up and down wonderfully. And the study showed that the improvement of the sham by 50% in symptom severity. That's a big deal in medicine. And so here's another example of a different patient. You can see that white line is that needle going in. That blue circle is the lidocaine, the medication sort of flowing around that muscle. I'm moving my hands around like you can see me, but I assume you're following what's going on there. So one of the side effects you see in this procedure is called a Horner syndrome. You want to see this. You want to see some ptosis, which is drooping of the eyelid. You want to see some anhidrosis, where you'll get decreased sweating on that side of the face, as well as meiosis. And you can see on this gentleman here that one eye is big pupil and one eye is a narrow pupil. That's a myotic pupil. Again, this is a response to dulling that sympathetic nerve. You get this overdrive of the parasympathetic side of things. You'll also see facial flushing, and I have patients who will say their nose is super stuffy and their conjunctiva will get bloodshot. Why do we care about this? Because this tells us, not 100%, but pretty close, that we're in the right place. That if the patient gets this symptomology afterwards, the medication was placed right where it should be because of the nature of the nerves that run right next to the sympathetic nerves in this ganglia, this gang of nerves. So what else can this stellate ganglion do? This block. We talked about PTSD, anosmia, which is inability to smell, long COVID, chronic fatigue, hot flashes, ventricular tachyarrhythmias, kind of a whole slew of things that this can help treat to reverse, because these are all tied into what? Sympathetic overdrive. Patients who get these shots will have better sleep, better memory and concentration, decrease in anxiety, panic attacks and depression, and ability to connect with others again, less jumpiness or nervousness, improved intimacy and sexual function. All things that all of us would, sign up for, I think. A lady this morning who had the first shot, came back for a second, was telling me that she said, I can't remember the last time my brain wasn't anxious. She said, I'm calm. I said, if this is what calm feels like, I will pay for this 100 times over. She said, I can go to the store now. I can function. I can interact with people again in a way that I haven't for years. And so those are the kind of things that you hear that's very rewarding, especially when it does happen. What about COVID? After recovering from COVID-19, we know that a significant proportion of individuals develop this long haul COVID, which he kind of already touched on, that fatigue, orthostatic intolerance, brain fog, inability to smell, inability to taste. It's one of my favorite words to say to patients: dysgeusia or geusia. I'm not sure I say it right. Anosmia. It's a good Scrabble word. You feel like the sickness behavior, but it's all the autonomic nervous system is just wacky. And we think there's these pro-inflammatory cytokines that are going crazy. We know there's an aberrant network adaptation to the sympathetic and parasympathetic imbalance. It gives this long-standing dysautonomia. And we do this as a reboot, which is what this little picture in the corner is, allowing the regional nervous system just to reboot. When you numb it, we don't use steroids now. When I first was doing it, I was using a little bit of a steroid because that's how I was trained. But we saw that some patients developed a steroid reaction and got anxious, which is the reverse of what we're trying to do. So we just do lidocaine and marcaine alone to, again, reboot this system. So how does long COVID play into this? We know that the sympathetic innervation to the head, neck, upper limbs, and upper thoracic region connect to the thymus, the heart, the lungs, the salivary glands, the thyroid. All these things are fed by the sympathetic chain. And if this picture shows you, it's not just one ganglion, there's actually three that I try to go after. So there's an inferior, middle, and a superior ganglion. So I will inject actually two levels in the neck, one at C6 and one at C4, again, trying to spread and capture as many nerves as possible. Where my clinic is, I'm in between two exits on the freeway. Some patients get off on 54th and some get off on 48th. And it kind of depends on how they travel. I think nerves are the same, that some will get off on one ganglion, but depending on anatomy, some get on another. So we try to get both of those to take care of some of this sympathetic overdrive. Here's another study. There's a pilot study for the ganglion block. It's a single arm pilot trial. The adult participants were COVID-19 diagnosis of greater than 12 months. They had to have that prior to enrollment, and they had to have this olfactory dysfunction. They were given bilateral SGPs, which means they had one side done and then quickly had the other side done. We don't do them at the same time because one of the side effects is you have a hard time breathing. And so if you knock off both sides, they might code, which is why we only do one side at a time. They were followed up for 1 month later, and according to the Clinical Global Impression Improvement Scale, a lot of words right there for smell loss, there was a change that was greater and significant in that 1 month. So of those 20 participants, mean age of 46, and they had it at least for 5 months, 10 of them experienced subjective improvement in their dysfunction. That's 50%. And again, another 55% had improvement in smell, and then another 35% in olfactory specific quality of life. So these numbers are about what I see in practice, that when people come post-COVID and have taste and smell issues, we're about 55 to 60%, where 6 out of 10 patients roll out and smell, hey, is that coffee down the hall? Or, hey, I can taste this chocolate again. And about 4 out of 10 will come out and say, hey, everything still tastes like garbage, or I can't smell anything. And it's is equally thrilling and disappointing, depending on which side of when they come out. But there was clinical significance. The conclusion is, according to this pilot study, SGBs for COVID-19 associated dysfunction of smelling was safe. It was modest improvements. It was and they said, hey, we should do some more trials, which I agree. Another study that was done, this was on 2 long COVID patients, again, a case series using a stellate ganglion block, showed that there was successful treatment of long COVID patients using that stellate block. And there was a lot of implications for dysautonomia as the pathophysiology of the long COVID. So this case series was important in our minds that proves that, hey, if we go after these sympathetic overdrive with local anesthetic blockade of this sympathetic chain, we can make a difference in people's lives who battled COVID and are still battling those symptoms. We think, and according to this paper, that their thought process was cerebral blood flow in humans is affected by the variety of inputs and regulated by all the sympathetic fibers extending from the cervical sympathetic chain. We've seen impaired blood flow associated with dysautonomia syndromes like long COVID, like myalgic encephalitis and chronic fatigue syndrome, MECFS, as well as postural orthostatic tachycardia syndrome, so POTS. So we see this overlap between long COVID, MECFS, as well as POTS. And there's this theory that there's a cerebral blood flow mismatch. So, which I found very fascinating, that there's a cerebral blood flow, there's a connection to that cervical sympathetic chain. When compared to healthy controls, the patients who had MECFS displayed reduced CBF and that blood flow, and then had impaired cognitive functioning that associated with that orthostatic testing. They also, another study showed impairment of the blood flow that was linearly related to disease severity. Another study showed that after strenuous mental tasks, that blood flow failed to recover normally in the regions in memory, goal orientation, and visual function. So we see this over and over again, that the blood flow may, and it probably is playing a role in these patients that we are battling on a daily, or challenged in helping them get a function of life. So this is just a redo of what I just said. So compared to health controls, these are the different studies that showed this. Stellate ganglion block causes, this paper called a luxury perfusion, which I like the term there. Basically what it means is there was a hyper reperfusion after the shot that allowed blood flow in excess of a local metabolic requirements. And that luxury perfusion, which I really like that term again, it helps alleviate those symptoms associated with that blood flow. And again, multiple other studies that showed improvement in anosmia after SGB. One of the things that I've really tried to dig into, try to figure out which of these patients are rolling out of my operating room who don't get benefit versus that do. Some of the theories of this COVID attacks, not just different parts of the brain. So the cranial nerve down near the nose, the support cells, if they're damaged or destroyed and don't recover, they may not get their smell back, versus someone who has just a blood flow issue or an inflammation issue in the brain are more likely to respond to this shot and get their smell and taste back. Let's see, effects. They noticed that the effects last longer than the duration of the lidocaine. And so there's a lingering effect. So we think that there's a local recalibration of the regional sympathetic influence, central integration of the effects of the blood flow. There's lots of hands in the pot, so to speak, and that there's a rebalancing of the interaction between the nervous system and immune system, which I like the thought of that all these things really work together, that aren't in silos, that the immune system, the nervous system, and the endocrine system really are interconnected in all these different ways. And we have found the sympathetic nervous system can be accessed through this block and can influence a lot of different directions. Here we go. They are thought to be separate functions. It's become clear that a couple of different studies showed that the nervous system and the immune system are actually quite together. So when you think about an inflammatory cascade like SIRS or ARDS, when the bacteria hits and launches the body response. If it overcompensates, it does it too much. And so we think there's a nerve immune interaction here. Nerve immune cascade. So there's a picture here. And this is my last slides. We'll kind of end with this. And it just really shows what we're trying to get at, that blue shot, that stellate ganglion block of that stellate ganglion, wherever there's another blue, it just shows its effects in the brain, in the spinal cord, in the sympathetic nervous system, where the receptors in the heart, receptors in the lungs, receptors on the immune cells, receptors in the intestine, and how it affects the cytokines. That it's a complex, so it's not easy. And so I tell patients, or when they ask, hey, when will this benefit me? When do I see the results? I say it could be 24 hours, it could be 24 days. Because there's a cascade involved, and it's not just, there's a domino effect. So sometimes it takes a while to see the benefit of that domino until it's gone through all the ranges. Kind of like damming a river. If you're downstream, you dam the river upstream, you still take maybe a day or two before you see the effects of the dam as it goes all the way down before it's dried up. And so I try to expectations lowered a little bit and say, all right, let's just follow up in a month and see how we're doing. So thank you.
Thank you, Dr. Conde. That was very helpful. We have about a half hour left, and I selfishly want to get to a case. But before we do that, there are a couple questions in the chat that I want to make sure that we do touch on, and then we'll see if we have enough time to kind of bring this all together with a case example. So I want to start and ask Dr. Yelman. Where did that question go? So sorry. Do you use hypertensive doses for beta blockers? And did you say that you use metropinol? Sorry, I'm probably saying that wrong. In it with pre-existing elevated blood pressure. How do most patients stay on the beta blockers? Some patients have a difficult time getting off of them.
Yeah, so as far as hypertensive doses, I'm not generally titrating beta blockers to hypertension. I'm generally titrating them to symptoms of sympathetic overdrive and, of course, to a heart rate goal. There are a subset of people who have pretty low heart rates to begin with and don't mount much of a heart rate response, even though they have orthostatic intolerance. It's not the traditional kind of sympathetic POTS type response to that orthostatic challenge. And so they often don't have room for beta blockers there. If I have a patient that may be someone that had essential hypertension even before they became sick with ME/CFS or long COVID, or is continuing to display huge variations in their blood pressures when they do get these sympathetic surges, I might be more likely to reach for something like metoprolol, which has a little more blood pressure effect than I would propranolol. But more often than not, I tend to go for things like propranolol and atenolol because of the lack of blood pressure effects. We're not really looking for that per se. And when I follow blood pressures in these patients, I see them as sort of a surrogate marker again for what is going on in their body. So if it's not someone that tends to be on the lower end of blood pressures, who's constantly needing volume and sodium to manage those symptoms, if it's someone who has got more of these sort of hypertensive responses every time their body has a physiological stressor, every time they go into a sympathetic state, then I try to just follow those blood pressures or have them keep a blood pressure journal that they associate with their symptoms. You can often see that, hey, as soon as I had spent an hour at lunch with a friend, that's when I started getting really hypertensive, or you get a sense of what those triggers are for people. And I generally just try to treat the underlying triggers and try to help manage the illness itself so that they don't have that physiological stress in the first place that drives that high blood pressure. Interestingly enough, and I've probably given this anecdote before, but occasionally I've seen situations where people have high blood pressures again because of the physiological stressors they're under. That's their kind of oversympathetic, amplified megaphone-like response. And you would think, oh, I have to give them an antihypertensive. And in fact, things like midodrine or droxidope that would increase their blood pressure, or fluids and salt that would increase their blood pressure actually bring it down, because you're resolving the issue that's driving that in the first place. You're actually taking care of that orthostatic intolerance or that physiological stressor that's driving that excessive sympathetic response. So don't be afraid to at least carefully dabble with those things if you think that's what's actually going on with your patient. And what was the third part of that question again, Talia?
How long do most patients stay on beta blockers? Some do have a difficult time getting off of them.
Yeah, I don't generally have a target for how long or short I'm going to be using them for therapy, right? They're not a course of antibiotics by any means. I would say I titrate to how people are doing over the course of their illness. I generally see a situation where in the first year or two where we're managing an illness, we're doing a lot on the pharmacological level to get things stable, and more than anything to really help keep people out of post-exertional malaise. When they start to achieve that with consistency is when they can start to increase things like physical activity, which of course beta blockers are somewhat in contrast with. And so as people start to be able to increase their physical activity and actually, exercise a little bit, of course, without triggering PEM, as they start to make gains in that fashion, I often see that they need less of the beta blockers. They need less of their orthostatic intolerance support measures, et cetera. So that's kind of, I think of that as sort of a second phase or phase two of managing this illness when you're chronically following it over time. But generally in the first year or two, when people are on them, they're probably not going to go off. And if they do, they probably are not going to do as well without them, assuming you found the right drug choice to begin with.
Thank you. Dr. Condi, I have a couple questions for you. What's the range and or how often do you use stellate ganglion blocks? How often should they be repeated? How often should they be, or what's the length of spacing them out? And then also, are there any indications for when you wouldn't use it or it wouldn't be appropriate to use it for that individual?
Good question. So one of the studies that I presented at the beginning, they did a two shot, 2 weeks apart. And so we sort of follow that protocol. There's another protocol that I also will use if the patient doesn't get any response from the right side, we'll do the left side, as there's a lot of crosstalk between the brain and some people are left-sided more or right-sided more. I wish I had an answer, a good one about nerves and how they act. But as we learned that they're like toddlers putting to bed, that you put them to bed and you hope they stay in bed, but then sometimes they want water or they need to go to the bathroom or they need a snack or they need another book and they keep coming back. And so sometimes it takes 1, 2, or 3 shots, but usually around that 2 to 3 marker, it can last months or longer. Sometimes 6 months later, we'll get someone to come back and do like a booster, so to speak. But about 2 to 3 early on will kind of give us an idea of if it's going to work. Sometimes 1 and sometimes 2. So it kind of depends on the symptom improvement. But because I've been in pain management for a long time and dealt with a lot of nerve syndromes after surgeries, and sometimes we don't know why these nerves, like CRPS, like why does it activate and stay activated, and then you try to numb it and turn it off, and sometimes it takes 1, 2, or 3 or more to kind of reset that nervous system and stop that feedback loop, which is we think is the biggest issue. Insurance has been a big issue. We've tried, it's covered for CRPS, and so if you've got pain down an arm, or we can even probably finagle pain into the face like a trigeminal nerve, that we can get insurance approval. But with that code that we use, that's the block code, we have submitted it, we've gotten off, and then we'll get denials left and right by most insurances. So we always still try, but a lot of insurances they're just not up to speed on our awesome data and this awesome stuff that we do. And so unfortunately, insurance won't often cover that. There was another question on signs. So there is some data that this may help migraines and headaches. A lot of the data is more for PTSD, COVID, and there's some on like trigeminal neuralgia, and those can be headache generators. If the headaches are coming from stress or anxiety or from previous trauma, then it will help a lot. But the classic migraines, not necessarily. I haven't tried it for Chiari. Let's see, what was another question? How often to beat it? How to get covered insurance? I haven't done a lot of on craniocervical instability, I haven't been able to correlate a lot of treatment with that and changes. So that's something I need to do more research on, the connection between the SGB and the instability, and if there's an improvement correlation with that. And then someone had asked if I work for Bateman Horne. I mean, I work with Bateman Horne and gladly do, but I have my own private practice. And so if patients want to be sent, we can definitely see them through that. To answer those questions?
Yeah, you did great. You did my job for me. Thank you.
I would also add, and I don't know if you've seen this, Dr. Condi, or not, but I've had 1 or 2 patients who have gone in for stellate ganglion blocks and come out with like a pain crisis. And the best we can tell is that if they indeed have CCI, craniocervical instability or atlantoaxial instability, that there might be something about the positioning for the appropriate administration of stellate ganglion blocks that can exacerbate that. Certainly, we haven't seen any predictive factors of that, and I've seen plenty of people with CCI get successful stellate ganglion blocks without these complications. But if there is a pain crisis afterwards, we do wonder if that might be what's taking place. Have you seen that in your practice?
Yeah, that makes sense. When you say pain crisis, are you talking like increase in neck pain or increase in pain like all over, or both?
I've seen full body pain. I've also seen sort of head, neck, face pain, and migraines or other headaches.
Yeah.
Also
One of the side effects of the block, I didn't mention that. So you got meiosis, hyperhidrosis, and headache. Like you can get this flushing, kind of get this like this increased blood flow that might actually cause increased pressure in the head and cause a headache. Or sometimes we get a rebound, which is like my least favorite thing that happens when you block a nerve, that when it comes back online again, it rebounds the other direction. And so the treatment you were trying to treat goes the other direction, and you get this pain like flare. And usually they are self-limited or not long. But I have seen, again, I've lost count, hundreds of these, that will you do a block on one side and a patient got really angry. And so we think that the sympathetic drive goes overdrive on the other side and tries to make up for it because the brain's trying to balance and figure it out. And so we get those patients in quickly and do the other side just to sort of balance it out. You can do this within 24 hours. So we don't have to wait 2 weeks. For the COVID patients, we often do a right side, left side. That's kind of our plan, because one person will get right side oranges but not chocolate, and do the other side, and now they can eat chocolate again.
With the getting really angry, you got to be careful. I had to give a patient prednisone for vasculitis once, and he threw his TV out a 2nd-story window, and his wife still says I owe him a TV.
Oh man, yikes.
I want to turn to Dr. Hoppers for a minute. So as a part of her case example, she brought forth a couple of tips to consider, especially if the individual is very mast cell reactive. Dr. Hoppers, do you want to touch on that? And I can even show your slide.
Sure. Can you hear me okay? Okay. Yeah, so the patient I have, so she's very mast cell reactive, and after the first block, she got a diffuse MCAS rash and itching. And do you have the slide up? You can see it started where the Band-Aid was, and just the first block, it was her neck, chest, upper back area. So, and she also had a little bit of a crash after that first block. So at the second block, we decided to we got a liter of fluid, and they did, I think, LR instead of normal saline, but they did give her a liter of LR. And then they used paper tape. And again, rash was worse this time, more diffuse, went down, arms as well. So the third block, again, no paper tape, but this time they did not use betadine. We were trying to kind of piece together what was causing the reaction. Again, gave her the liter of fluid, but added Benadryl to it. And so after that one, the rash was very mild, much better, but she was a little bit tired, but not a real crash afterward. And then finally on the last one, we got it right. because actually what they did is they accidentally did get a little bit of betadine on her at that third block. So on the fourth block, they did paper tape, no betadine, the liter of fluid, 50 milligrams of diphenhydramine, and she just had a little bit of itching, but never had a rash, and she did not crash at all. So I had another patient, very similar to her, actually, with a lot of MCAS issues. And so we just started from the get-go with the fluid and the diphenhydramine, and she did great. So that's what I usually do if they have MCAS. I ask them to do that. I have to ask to get that done. Typically, they don't do it every time.
So your recommendation would be if you know that the individual is particularly mast cell.
Yeah, go ahead and do
sensitive.
go ahead and do diphenhydramine. And especially if they have like severe ME/CFS or long COVID where they crash a lot, the fluids tend to help with the crashes. And so I did that as well, because just getting there, you got to check in, you got to sit and wait, you got the lights and the sounds and the people, then you're getting new medicines, which, all these things that can cause a crash. So just trying to do some things to prevent that from the get-go is helpful.
It's completely off-label, but there are some reports of people using Flovent and spraying it over an area before applying an adhesive bandage, and that seems to reduce some of the local mast cell reactions as well.
Thank you. I'm not sure if we answered this or not, so please forgive me if we already did, but Dr. Condi, do you use fluoroscopy or any kind of radiation for the block? And does it ever permanently, get rid of
Reduce
symptoms?
I think the data is too early to tell on these studies that whether it's permanent or not. I use an ultrasound. I have used fluoroscopy in the past when I first started this, and I was actually using both just because I wanted to make sure I got it right and was watching everything. And as I've practiced longer, I've been able to just do ultrasound, and I feel very confident in the technique that we don't need to use any fluoroscopy. And I have seen patients who have had it and have not come back. Now, I assume it's because it worked, not because it didn't. But I think that in our world we live in, if your nervous system is prone to upregulate because of stressful situations, those don't go away. And so I say, hey, I'd love it if it never came back, but I'm prepared if it does.
I would
Right.
say, certainly in my clinical experience, patients who've been to see Dr. Condi and had this done, that there are certainly a few that it just doesn't quite help and they don't come back for that reason. Sometimes they don't come back because they get a big bill when insurance doesn't cover it. But a lot of times they do get benefit. But I think what happens is we try to use a stellate block, understanding that it may not be forever, that it does wear off at some point. We really try to use the window of benefit from a stellate ganglion block clinically to then introduce something else that they may have not been tolerating before, or to do something different in their clinical practice that they weren't able to tolerate before they got the benefits of the stellate ganglion block. And then they start to build additional clinical improvements on top of that, and then maybe repeats aren't quite as necessary down the road as well.
And
Dr. Brown?
Yeah, thanks for the presentation, because we get a lot of questions about this. Yeah, the insurance thing has been a barrier. The other question I have, though, is these prior studies, did any of them include sham procedures?
yes, they did. One of them, the big one that from the Journal of the JAMA for Psychiatry, I think it was 2021. I'll go back and look at it, but yeah, there was a sham versus lidocaine, and so they're definitely
That was PTSD.
Yep, that was for PTSD. Yep. So I wish there was bigger, better studies for the dysautonomia, but a lot of them are mostly case presentations, case studies. And so, yeah.
Can you speak to the use of steroids in the blocks? Is this something we should ask the specialist not to use for these patients, especially those who might be mast cell triggered?
Yeah, so this is something that Dr. Yeoman and I encountered early on, because again, I used to use steroids. That's how I was trained, and I was back at the VA in Virginia. And then as I've done more and more of these and have expanded and done more research and studying and talking to Dr. Yeoman, we opted not to use steroids for that exact reason. And I think that we've had as good, if not better, results and without some of the side effects. So yes, I would ask the specialist not to use a steroid and just use the Marcaine or whatever their preferred cane. Some will use ropivacaine, but yeah, to avoid any of that potential.
Dr. Yeoman, you touched on this just a little bit, but I don't want this to seem like we're just doing this echo as a big shout out for stellate ganglion blocks. In your presentation, you clearly covered that there are other means that you go to in your repository. Within that, what have you found the most helpful for patients?
It is completely unique to every single patient. And I think you have to always take into account the entire clinical situation, what a patient's vital signs are, blood pressures and heart rates that don't allow for alpha blockers and beta blockers, which tend to be my first line agents, kind of complicate things. Obviously, as effective as benzodiazepines are, you have to be really careful with how you utilize them and not overdoing it there and not creating more fatigue or other problems when you're dealing with other issues at the same time. Kind of depends on how resistant people are to those sort of initial therapies, if they're able to even concentrate on things like brain retraining programs. I've had people not be able to tolerate vagal maneuvers. So it all really kind of depends on the clinical scenario. I wouldn't say there's one that's better than another per se, but I do tend to think about alpha and beta blockers as first line.
Dr. Yeoman, can I interject for a second? Have you used the guanfacine for post-COVID to any benefit?
I have in certain cases. I don't tend to reach for it primarily for sympathetic overdrive symptoms. It's generally more when people have overwhelming brain fog and want to do better from a concentration and focus perspective, but they also have a lot of overlay of sympathetic overdrive. You can't really use stimulant therapies in those patients. And if they're trying to like hang on to a job part-time, they really need to concentrate, even though that may not be my number one clinical priority, it is for them. Guanfacine is sometimes a good choice in those circumstances.
So I read that study and I was wondering if that would be of benefit. I was curious if you had said, thanks for sharing that.
I would
With
also
regard,
point out a
sorry.
random fact here that I was just thinking about, which is that some of you may be aware that patients with HEDS or other connective tissue disorders have been found to be less responsive to the canes from a perspective of analgesia. And like in dental procedures, if you go and look at dental literature, there's a lot of reports of this. And what's interesting is that that does not seem to be relevant to the efficacy of stellate ganglion blocks.
It's just relevant when you're trying to numb them to do the procedure.
I leave that to you.
And we maybe use a little more sedation. The good news is the procedure is fast. I mean, that's probably the wrong way. It's efficient. How about that? It's not a very long, lengthy procedure, and which is nice, so that if there's some discomfort, it's a little bit of lidocaine inject. And again, even though 2 levels, I'd say time in the body, needle in the skin, 2 minutes.
Dr. Brown?
So Braden, can you just walk through kind of briefly, and it's kind of hard and tendency to oversimplify, but for providers who are sort of looking at all these things, like where does the stellate ganglion block fall in your sort of algorithm of when you sort of pull, what are the things that make you think about that over other therapies, or when in your algorithm do you sort of hit that point?
I would say the most common time that I start to reach for a stellate ganglion block is for people who have a lot of medication sensitivities. So when they begin to take something, they have these paradoxical reactions or huge sympathetic reactions that are non-pharmacological reactions to medicines. There's all these different classes of drugs that they're struggling to take. You can't really make any dent in any of their symptoms whatsoever. I've certainly seen stellate ganglion blocks as a procedure, especially a series of a couple, calm some of that down so you can start to introduce other therapies that might be helpful to that patient, whether it's alpha and beta blockers for sympathetic overdrive, whether it's something for OI or for mast cell activation. That's a situation in particular that stands out to me where a stellate ganglion block is particularly helpful. Other times I have people maxed out on alpha blockers and beta blockers. They might be taking some benzodiazepines and they are still just jumping off the wall. It's amazing how resistant they can be to things. So stellate ganglion block can be a great tool there too.
I think it's good in the beginning, in the middle, in the end. I just think that more is better.
I think if they were always certain to get insurance coverage and money
that's
no
true.
object, I think it would be easier to argue for it being more of a first line kind of therapy. And sometimes it still is.
Yep, no, I agree. I wish this is one of those things where I really wish the insurance was up to date on the data and the research and going line. We have, the tricky thing is we've debated looking at different codes for this procedure, and you start kind of this gray area of like, is not exactly a peripheral nerve, but you can code it differently, sort of. I just would hate to get in that quagmire if Medicare is like, wait a second, that's not the right code. I'm going to take all your money now. So we're trying to be very careful with that, but maybe there's some ways we can look at that.
I want to ask one more question, and perhaps this is slightly controversial, but I've at least experienced this with a couple of different patients where, because stellate ganglion blocks have become more known in this post-infectious world, people are turning to them a little bit more. There's also a bit of a opportunity for people who might be trying to just, make a buck off of this. How would you advise the providers to go about that referral to someone who does do the stellate ganglion blocks to know that they're really in the right hands, their patients in the right hands?
So the question is, I'm trying to understand exactly what that question. Are you asking if a provider is charging too much for the procedure, maybe they're the wrong person to do it?
How do we know a trusted clinical partner other than yourself? How do we know who to refer to get this done correctly that's not maybe a little integrative medicine leaning and would be happy to give you a Myers cocktail and ozone and several other things that may or may not be as evidence-based?
There are definitely members of our community that like to do that, and I will just stop there. I think that I do work with another company called Stella. They're a national company, and they've hired me to do patients for them. They've sent me patients, and part of their protocol is that's where I learned the double shot, the C6 and C4, and extra training. And not everyone does that. Again, kind of there's some data to support that gives more benefit, but there's not a lot of docs that do this on a regular, or they do it or feel comfortable doing it. My first job I worked with, the doc, he had no desire to do this shot because of where it was in the neck. And he's like, I really wasn't trained on that. I have no desire. You can have them all. And so I don't have a good answer for that, because I think that it is done and there are some that do it, but it kind of depends on your training and background. And if your attending showed you how to do it and you felt really comfortable doing it. But so I can't give a good answer to that.
It was a tough question. I think I was more just trying to make sure that I brought light to, the importance of just vetting and making sure that you're sending a referral to someone that's trusted. And so I want to really thank you both for your time today, and thank you to everyone that joined us. Be on the lookout for that CME email. Just as a reminder, you have to claim that CME by midnight tonight, and we hope to see you on March 7th. Until then, take care.